Hi everybody, welcome to our module on metabolic bone disorders. This is the last and final lecture of our musculoskeletal system series. Before beginning with the video, I'd like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everybody. If you wish to support its continued development, or if you had liked the content and wish to and would help us build a team, voluntary contributions are welcome. So you can pay us with any of the payment methods at the link that is on the screen, and that's also pinned in the description. Now we move to the final lecture of the musculoskeletal system series, the metabolic bone disorders. Metabolic bone disorders occur when there is a abnormal balance between bone formation, bone resorption, and mineral metabolism. So these disorders affect bone density, bone strength, and mineralization of the bone matrix. Several metabolic bone diseases are particularly important for exams. So these would include osteoporosis, osteomalacia, rickets, Paget's disease of bone, and bone changes that are associated with hyperparathyroidism. So whenever you come across questions, so diagnosis usually depends on combining three important clues. So these includes clinical features, laboratory findings, and imaging, characteristic imaging patterns or findings or whatever they might be. So to understand metabolic bone diseases, we must first review normal bone remodeling. So bone is constantly undergoing a process of renewal. So this process involves two major cell types. Osteoclasts are responsible for bone resorption, meaning they break down old bone tissue, whereas osteoblasts are responsible for bone formation and deposition of new bone matrix. This balance between bone resorption and bone formation maintains the bone strength and also helps regulate calcium levels in the body. Bone remodeling is controlled by several hormones, including thyroid hormone, vitamin D, and calcitonin. So, when this balance becomes disrupted, metabolic bone diseases can eventually develop. Osteoporosis is the most common metabolic bone disorder. It is characterized by decreased bone mass and increased bone fragility. Because the bone becomes weaker, patients with osteoporosis are at a higher risk of fractures. The most common fracture sites includes the vertebrae, hip, and the distal radius. Osteoporosis is especially common in postmenopausal women and elderly individuals. Osteoporosis develops when bone resorption exceeds bone formation. When resorption exceeds formation. One of the most important causes is estrogen deficiency, which commonly occurs after menopause. What estrogen does is it normally inhibits osteoclast activity by inducing secretion of something called as an osteoprotein, as we have already discussed in the previous modules of this musculoskeletal system series. We've discussed about osteoprotein or OPG. So what estrogen does is it increases the OPG levels, and in turn OPG inactivates the osteoclast, and this way, by a complex cascade, estrogen finally inhibits resorption by the osteoclast. So, but when there's estrogen deficiency in postmenopausal women, what eventually happens is there is deficiency of osteoprotectin, so there is reduced inhibition of osteoclasts, and this reduced inhibition of osteoclasts would eventually lead to increased bone resorption. Other contributing factors would include aging, inadequate calcium intake, and lack of physical activity. So, over time, these factors would lead to progressive loss of bone mass. Osteoporosis is often called silent disease because it may not produce until a fracture occurs. The most common fractures are vertebral compression fractures. These fractures may cause back pain, loss of height, and the development of kyphosis, sometimes called as the Dover-Hager's hump. So, Dover-Hager's hump is the characteristic feature that is seen in kyphosis. So, hip fractures are particularly serious in elderly patients because they are associated with significant morbidity and mortality. Diagnosis of osteoporosis is confirmed using bone mineral density measurement, typically with a DEXA scan, as we might have heard about something called as a DEXA scan that is used in the elderly people for screening the risk of osteoporosis. Osteomalacia is a metabolic bone disorder that is characterized by defective mineralization of bone matrix in adults. The most common cause is vitamin D deficiency because the bone matrix is not properly mineralized. The bones become soft and weak. Patients may develop bone pain, muscle weakness, and an increased risk of fractures. Unlike osteoporosis, the amount of bone matrix may be normal, but the mineralization of that matrix is defective. Where in osteoporosis, what is happening is that the amount of bone matrix is reduced, whereas in osteomalacia, what happens is the amount of bone matrix is normal, but the defective thing, what is defective in osteomalacia is the mineralization of that already present bone matrix. So there is a reduced mineralization of the bone matrix. Vitamin D deficiency can occur for several reasons. The most common causes would include inadequate dietary intake, limited sun exposure, malabsorption disorders, and chronic kidney disease. Vitamin D vitamin D actually plays a crucial role in calcium absorption from the intestine and for the maintenance of normal bone mineralization. So whenever these vitamin D levels are low, what happens is calcium absorption from the gut decreases and bone mineralization also becomes impaired. So with this vitamin D, which is particularly essential for calcium absorption, when this vitamin D is deficient, there is reduced absorption of calcium from the gut, and this reduced absorption can eventually present with reduced bone mineralization. Patients with osteomalacia often present with diffuse bone pain and muscle weakness. They may also have difficulty walking due to weakness in the proximal muscles, like the hip girdle muscles, and bone tenderness and increased fracture risk are common findings that are seen in patients with osteomalacia. So laboratory findings often show low vitamin D levels, low calcium levels, and elevated alkaline phosphatase. And this elevated alkaline phosphatase is uh, probably due to increased bone turnover. So whenever there's increased bone formation that's happening, or increased bone resorption formation, so both of these happening together is called as turnover. So whenever there's increased turnover, there is elevated alkaline phosphatase. There is low vitamin D and low calcium levels also. Rickets is essentially the pediatric form of osteomalacia. So it occurs in children when vitamin D deficiency interferes with normal bone mineralization during growth. So because children's bones are still developing, what happens is defective mineralization leads to skeletal deformities. Children with rickets may develop several characteristic skeletal abnormalities. So these includes bowing of legs, delayed growth, widening of growth plates. Uh, Other classic findings would include rickety rosary, which is enlargement of the costochondral junctions. So we can just see the enlargement of the costochondral junctions on this particular X-ray, where there is hyperlucent area, where there are hyperlucent areas at the costochondral junctions. Costochondral junction is nothing but the place where the cartilage and the rib cage bones meet, and this is called as the costochondral junction. And there's we can also see frontal bossing of skull and delayed tooth eruption. There's unusual skull shape, and there are also dental problems. There is a delayed tooth eruption. These deformities occur because poorly mineralized bone cannot support normal growth. So whenever there's poor mineralization happening because of reduced vitamin D, which in turn leads to reduced calcium, there's poor bone mineralization, and this will eventually lead to bony deformities. Paget disease of bone is a chronic disorder of abnormal bone remodeling. So the disease progresses through three stages. The first stage is excessive bone resorption because of excess of osteoclast activity. The second stage is when the osteoblasts attempt to compensate by producing a new bone, and however, this newly formed bone is disorganized and still it is structurally weak. So this weakness leads to enlarged and deformed bones that are more prone to fractures. There's an increased fracture risk in those patients who suffer with Paget disease of bone. This most commonly affects older adults. In Paget disease, the initial problem is excessive osteoclast activity. So this causes rapid breakdown of bone. The body attempts to compensate by increasing osteoblast activity. However, the new bone that forms is disorganized and is structurally abnormal. As a result, the bone becomes enlarged, but it's still weaker than the normal bone. Many patients with Paget disease are initially asymptomatic. When symptoms occur, they often include bone pain and deformities. One common finding is enlargement of the skull, which may lead to hearing loss because of compression of the nearby nerves. So whenever there's enlargement of the skull, this might lead to compression of the hearing loss due to compression of the nearby nerves. Compression of the skull would lead to compression of the nearby nerve. Enlargement of the skull would lead to compression of the nearby nerves, and this compression of the nearby nerves would eventually lead to hearing loss. So bowing of long bones is also a characteristic feature in those patients with Paget disease, and there is also increased fracture risk in those patients who suffer with Paget disease of bone, because that's just nothing but and a weak bone. One of the most characteristic laboratory findings in Paget disease is elevated alkaline phosphatase. So this elevated alkaline phosphatase, as we have already discussed in the last few slides. So whenever this alkaline phosphatase elevates, whenever there's increased bone turnover. So this reflects increased turnover in Paget disease of bone. Calcium and phosphate levels are usually normal. The diagnosis is supported by a combination of laboratory findings and characteristic radiological changes. Radiological imaging often shows thickened cortex. The cortex is thickened, and there's enlargement of bones and areas of mixed lytic and sclerotic lesions. So one classic imaging feature is cotton wool appearance of the skull. So this helps us identify a characteristic pattern that is seen in Paget disease. This is nothing but cotton wool appearance of the skull. This appearance results from irregular bone remodeling. Hyperparathyroidism occurs when the parathyroid glands produce excessive parathyroid hormone. This parathyroid hormone normally plays an important role in regulating calcium levels in our body. So, whenever these parathyroid hormone levels are elevated, what happens eventually is bone resorption increases. So, whenever bone resorption increases, it increases calcium in the bloodstream because more and more calcium is being resorbed from the bone into the circulation. Parathyroid hormone stimulates osteoclast activity indirectly. So it first acts on the osteoblasts, which then signals the osteoclasts to increase resorption. PTH stimulates blasts, whereas osteoblasts activate osteoclasts through signaling pathway. Blasts activate clasts. The process releases calcium from the bone into the bloodstream, and this is a result of breakdown of the bone matrix. Chronic elevation of parathyroid hormone therefore leads to progressive bone loss and weakening of the skeleton. Osteitis fibrosa cystica is a severe skeletal manifestation of hyperparathyroidism. So, in this condition, excessive bone resorption causes the bone to be replaced by fibrous tissue. This leads to cyst-like bone lesions, skeletal deformities, and increased fracture risk. Brown tumors are nothing but focal bone lesions that are seen in severe cases of hyperparathyroidism. So they consist of osteoclasts, fibrous tissue, and deposits of hemosiderin. So the brown coloration that results from hemorrhage and hemosiderin accumulation. So despite their name, these are not true tumors, but rather they are reactive lesions that are caused by excessive bone resorption. In primary hyperparathyroidism, laboratory tests typically show elevated calcium, elevated parathyroid hormone levels, and low phosphate levels. In secondary hyperparathyroidism, parathyroid hormone levels are elevated, but calcium levels may be low or normal. These laboratory patterns helps us differentiate the underlying cause of hyperparathyroidism. Now let's compare two important metabolic bone disorders that are frequently tested in exams. The one is osteoporosis and the other one is osteomalacia. In osteoporosis, the main problem is a decrease in the bone mass, whereas uh, in osteomalacia, the main problem is defective bone mineralization. In osteoporosis, the main problem is decrease in the bone mass. The bone matrix is normally mineralized, but there is simply less bone overall. Whereas in contrast, in osteomalacia, it occurs when bone mineralization is defective. The bone matrix is present, but it is not properly mineralized. So this is typically because of vitamin D deficiency. Clinically, osteoporosis usually presents with fragility fractures, especially in elderly patients, whereas osteomalacia typically presents with bone pain and muscle weakness and difficulty walking. So, whenever someone asks a question regarding osteoporosis or osteomalacia, we can just think of simple tips. So, low bone density suggests osteoporosis, while defective mineralization suggests osteomalacia. Rickets and osteomalacia are closely related to uh, each other because both results from vitamin D deficiency. The only difference that lies is the age group affected. Rickets occurs in children where bone growth plates are still open because the bones are still developing. Defective mineralization causes skeletal deformities, whereas these deformities includes bowed legs, widening of the growth plates, and characteristic features such as rachitic rosary at the costochondral junctions. Whereas osteomalacia, on the other hand, occurs in adults since adult bones have already finished growing. The disease presents mainly with bone pain, muscle weakness, and increased fracture risk. So, whenever a question mentions a child with bowed legs, it strongly suggests rickets. Paget disease of bone has several characteristic features that help us identify it in clinical scenarios. So it usually affects older adults, typically over the age of 50 years of age. Patients might present with bone pain, bone deformities, enlargement of bones such as skull, enlargement of long bones. So if the skull is involved, patients may develop hearing loss due to compression of the nearby nerves. So laboratory findings typically show elevated alkaline phosphatase, reflecting increased bone turnover. A classic imaging feature is cotton wool appearance of the skull in Paget disease of bone. Another important complication is the increased risk of developing osteosarcoma. So this Paget's disease might progress to a neoplastic transformation in the form of an osteosarcoma. Hyperparathyroidism causes excessive secretion of parathyroid hormone, which significantly affects bone metabolism. Parathyroid hormone usually increases bone resorption, leading to release of calcium from the bone into the bloodstream. As a result, patients develop elevated blood calcium levels, and also progressive bone loss is also a possibility. Characteristic skeletal changes includes osteitis fibrosa cystica, which occurs when the bone is replaced by fibrous tissue. Another feature is the formation of brown tumors, which are reactive bone lesions that are caused by excessive osteoclast activity. Clinically, hyperparathyroidism is often remembered by the phrase. We might have known about it. This is a quite popular phrase. Bones, stones, abdominal groans, and psychiatric overtones. Bones are involved. Stones, renal stones are a possibility. Abdominal groans and psychiatric overtones, neurological and psychiatric deficits are a possibility. To conclude the musculoskeletal system series, now just quickly review the most important diagnostic patterns for metabolic bone disorders. So, fragility fractures in elderly patients are most commonly caused by osteoporosis, whereas vitamin D deficiency leading to defective bone mineralization. Whereas vitamin D deficiency leading to defective bone mineralization leads to osteomalacia and rickets. Elevated alkaline phosphatase along with bone enlargement, might suggest Paget disease of bone. Hyperparathyroidism produces increased bone resorption and elevated blood calcium levels. So recognizing these clinical patterns will definitely help us in rapidly diagnosing all those metabolic bone disorders. So pattern recognition is the key for solving any kind of USMLE question. So pattern recognition will definitely save you. Just try to understand or try to learn the key patterns of identifying the condition. So this is the last video of our musculoskeletal system series. Thank you for watching till the end of the series. I would like to request all of you to subscribe and keep supporting. We'll be getting back to you with much more useful content.